I will call upon this next speaker, Dr. Satyanarayana Reddy. Dr. Satyanarayana Reddy is a very eminent speaker and associated with the CSEPI since long. And he is a professor of obstetrics and gynecology. He is from Hyderabad, consultant in sexual medicine at Hyderabad. He is having more than 50 research papers in journal. He has contributed various chapters in 16 books. He is co-author of 3 books of sexual medicine. Recipient of Best Doctor Award 6 times and Chief Minister's Gold Plate 2 times for Government of Andhra Pradesh. I welcome Dr. Reddy to give his talk on this cancer.
The topic is cancer and sexuality. Now, here, cancer is a death. People have cancer, they die. Now, people are living with cancer, having a cancer but living. And people are living free of cancer. These two candidates, that is, people who are living with cancer, not treated, people who are living free of cancer, these two classes of the people are benefited by treatments. Now in India, around 1 in 1,000 is the incidence of new cancer each year, and more than 2.8 billion, that is, prevalence is 2 per 1,000. If you take into consideration death and then incidence, in the world we don't go because of time. And these are the incidence of cancer, the prevalence of cancer. We are not concerned with the incidence. It is for theoretical sake only. We are concerned with the prevalence of cancer. Now you can see in a woman, cervical and breast cancers are common. Then in a man, oral cancer, colorectal cancer, followed by prostatic cancers. These people are living with cancer, are living free of cancer. We are not concerned with some other cancers where people die. Now, cancers affect sexuality in 3 different dimensions. Number 1, in a sexual function. Number 2, in identity of the sex. Sexual identity won't mean whether they are transsexual or not. No, identity of ourselves, feeling myself as male. And sexual relationship. Now, the sexual consequence of cancer physically, it can happen in the time of diagnosis. It can happen at the time of surgery. It can happen at the time of radiotherapy or chemotherapy or with medications used. Now, sexual consequences of cancer at diagnosis, life is at stake. They are shattered and they are worried about their sexuality becomes zero. Finances are arranged, so many things has to be done. So, not worried about sex. The last line is much more important for us. Good number of the people who are going to die in 3 months time or 6 months time, they wanted to enjoy sex, full of it. This is one of the common things which we receive today. The sexual consequence of the cancer in men, there are 2. One is directly affecting the sex, and the second one is indirectly affecting the sex. In men, the direct is, anybody will be able to understand what is amputation of the cervix, orchidectomy. The implications anybody can understand. Or removal of the prostate and seminal vesicles. This for retrograde ejaculation. Afterwards we come. Then in the radical pelvic surgeries, all the nerves to the genitals, all the blood supply to the genitals come from the back to the front. When you clear the pelvis, pelvic excenteration will be done. Yes, common thing is abdominopedial resection for a coronary cancers and throat cancer and amputation of the limbs. Indirectly, by means of a colostomy, by means of incontinence of urine. Whereas in a woman, the direct consequences of a carcinoma of vulva, you can understand loss of erogenous zone. Or in a case of operations, vertical cystectomy, there is a shortening of the vagina, and there is a surgical menopause in all cases of radical hysterectomy. Then radical pelvic surgeries, any pelvic surgery is going to damage the blood supply and blood supply to the genitals. Lymph node removal, very simple. Indirect is, women are more worried about the cancer, they are more worried about the scars and disfigurement, the breast removal. Now, at radiotherapy, immediately we are not concerned with, it is a short term only. But in men, usually sexual consequences of cancer radiotherapy In surgery, it starts and it improves progressively. That is, a little betterment will be there. But in a case of cancer, radiotherapy, it starts in minimal and in due course of time, the complications will be more, sexual complications, any complications. In men, the testes charge, vascular and neural damage will be there. In a woman, radiation menopause and after cancer, irradiation, the vagina will get shortened, vagina will get stenosed, it gets dried up. So shortened, stenosed, inelastic vagina will be there for irradiation of cancer. Now, with chemotherapy, the immediate effects we are not concerned with, but the late effects are all cancer drugs are neurotoxic and they can destroy or they can damage the gonads and can result in infertility. And the sexual effects of radiotherapy or chemotherapy won't be appearing immediately. It takes a minimum of about 1 to 2 years also for people to manifest. It takes a little longer time. Then sexual consequences of the medications they are taking. Antidepressants, seduction, narcotics are so common. These people will be having their consequences. Corticosteroids are given for a good number of people. Androgen deprivation therapy for men in a prostate cancer, whereas hormone deprivation therapy for a woman in a case of cancer breast. These things are going to affect the sexuality. Now, at 3 different levels, at a hormonal level, neural level, and vascular level. Because shortly at the time, I am going to speak good number of the slides. Now, this to simplify the things. Everybody knows that there is a desire phase, excitement phase, erection, and then lubrication, orgasm phase. By and large, I am not sticking to the wording, but by and large, in general, desire, organic, not psychogenic, organic diseases, desire is endocrinological, whereas arousal is cardiovascular, vascular, whereas orgasm is neural. So any damage here, that is one. That is, a desire less will be there when there is a chemotherapy, radiotherapy, castration, hormonal therapy. Erection failures will be there when there is a surgery over the arteries, nerves. Then orgasm will be damaged by means of neural supply less and SSRIs. Now, we go for the common sexual dysfunctions in common diseases. In a case of breast cancer, it happens in younger women, and the prevalence is high because good number of the women will survive after cancer breast. Good number are living. But the problem is here, there is a loss of sex symbol for life. Then there is a loss of erogenous zone, and scarring will be there, lymphedema can be there. And anti-estrogen therapy, usually tamoxifen will be given for a cancer breast. Now, in a vulvar cancer, anybody can identify when vulvar cancer, you will chop off everything. There will be only one hole there, just like a hole in a wall. It will be like that only for a vulvar cancer. Carcinoma of the cervix, uterus, and ovary, if they do radical hysterectomy, then it will be shortened, stenosed, dry vagina. There is no lubrication, there is no swelling lubrication reaction, and because she is not having estrogen, then all of these things are results. Atrophy of the breast and vagina, nobody will be talking about this one. Breast and vulva, the health is vulva, vagina health is maintained by estrogen. When she is not having estrogen, the size of the breast goes down in a post-operative cancer for this hysterectomy. Then it results in infertility. Now, in a prostate cancer, more amount of time is spent, and then literature is given that prostate cancer, what are the complications? Everybody is so fond of. But in fact, good number of the people are living with prostate cancer surgeries. But they are quite old people and their interest is lesser. That is, they are spent forces. We did not spend our time over spent forces. Now, in a man, testicular cancer, it usually occurs in young men. Bilateral orchidectomy, chapter is closed. but still there is something there, something different. Suppose if there is a testicular cancer in much more younger people, less than the age of puberty, then the treatment will be different. After puberty, the treatment is different. Elderly, the treatment will be different. But always there is hypogonadism. There is always infertility. In a case of penile cancer, amputation is the treatment. So where is the question of having sex? For that one also there is a treatment. In the cancers affecting men and women, common. Colorectal cancer, I told you, colorectal cancer, in all colorectal cancers, the pelvis will be cleared of every tissue. So no blood supply, no nerve supply to the genitals. That is sexual function. Now we are going to the sexual identity. What does it mean? In men, after something, when a sexual organ is damaged, he feels less of a man. That is the first one. This is the more common reason for having a problem. And he feels that he is a physically challenged man in sex, even though he is not having a hand, he is not bothered about. So this is one of the common reasons. Suppose a 70-year-old man comes to you with a prostate cancer, and if you tell that man your balls will be chopped off, he won't be getting operation done. Yes, a good number of the people, they don't use it. It's a vestigial organ, the penis is a vestigial organ for those people. Still, they wanted to they wanted to die with a balls on, not with balls off.
So the rating is
That is the loss of a penis and loss of penile length. Loss of a penis is anybody can understand. But in all cases of prostate operated, there will be lessening of the length of the penis by about half centimeter. It is standard, and stomas will be there. And in a woman, the sexual identity is more. They feel that when they are not having a breast, they feel loss of femininity. And in fact, loss of femininity is not only because of the loss of an organ, it is because loss of estrogen support to her. The next one is loss of breast, and then hair loss they are more worried about after chemotherapy. Then after sexual identity, we go for a sexual relationship. This is causing more problem in sexuality than anything else. So the psychological aspects are, the woman feels, suppose a woman underwent a breast cancer surgery, imagine, I am less attractive, I am less desirable, she feels. So she don't initiate sex on her own, or she don't respond to the sexual activity of the husband. Then what the man thinks? The man thinks that she is not ready for sex. This is the response. This is the original of the woman. This is the response of the man. She is not ready for sex. She may not like my initiation of sex. When I am dying of cancer, you want me to participate in sex. He thinks she may be liking it, but he thinks. So she may feel that he is for sex only. This is the response of the man for the non-initiation of the wife. Next one is the man, when there is no initiation from the man, that is the reverse response to the response. He feels that I am not fit for sex. I am not able to give him pleasure. Then he may seek pleasure somewhere. So in this conflicting ideas of her reaction, his reaction, and her super reaction is going to damage the sexuality. So people think that sex is forbidden in cancer. This is so common. Then the fear of transmission of cancer. Every woman, the husband of every man, every woman who underwent cancer surgery, am I going to have it? That is common. Here, the next one is love is replaced by sympathy. A woman having love is replaced by sympathy. Romance is replaced by concern towards others. Then sex is replaced by nihilism. Say no, nothing. So they feel themselves as no. Then what to do? How to manage? The first management is education. The second one is open discussion. You have 10 people that sex is possible or sex is equally possible, and don't think that the other partner is not willing for sex. So here you have to tell that, suppose you are not participating in sex, imagine. If you participate, you may not enjoy, but at least your partner will be able to enjoy. If you don't participate, both both of you are not enjoying. Then what is the solution? At least instead of no chapati, you have one chapati. That is the one. That is a simple education telling that it is not a transmittable disease. People can have sex. Anything is possible. The second one is open discussion between the doctor, the woman, and the husband. All of the earlier ones are imaginations. Now, what to do with management of the sexual dysfunctions in a man after cancer? I'm having time, sir. How much? 5 minutes?
No.
2 minutes, less than. Then, hormone replacement therapy, if it is testis removed, and testis can be managed by testicular implants. In the case of amputation of the penis, you can do penis extenders are there available. Not here. In Western countries, we have got something. Strap-on dildos, just like two women will do, the same way. The next one, treatment for erectile dysfunction, just as in either case, treatment for ejaculatory dysfunction, just for any other case, and penile rehabilitation for a carcinoma of prostate. This is there, we routinely do it. Then in woman, hormone replacement therapy, in a case of cancer vagina and cancer of the cervix, immediately after you have to service it by means of vaginal dilation to prevent it from getting closed. Then lubricants can be used, breast implants can be done, and wigs can be given. And preservation of the fertility in a young, good number of people are now young, and particularly breast cancer patients. Fertility, that is sperm and oocyte freezing, that is the norm today. And donor gametes, they will be kept there. Donor gametes if they need. Then surrogacy, if she is not having uterus. Now, this is more important than this. Once there is a cancer, there should be a reorientation of their sexuality. So, everybody has to find that now with the treatment, they have to reorient. You can see how the sexuality goes down. But after treatment, it is so much difference will be there. When people think that it is a new me, I have to accept my new reality and then has to respond to my new realities. Then the couple has to say, new we. That is the solution. Reorienting, that is, everywhere you have to tell those people penetrative sex is not the only form of sex. Sex is not restricted to genitals. There are non-genital ways of delivering of sex. If not both, at least one partner can be satisfied if you do sex. The reverse way. How sex affects cancer? The reverse way. We are thinking of cancer affecting sex. That is, almost all cases of cancer cervix are squamous cell, because everybody may be knowing, but they don't know these things. And the last one is more interesting, but not realistic. Everybody knows it. As cervical cancer for carcinoma cervix, that is vaccination is now being given. So now, today it is going to be released, and this book contains a chapter on cancer and sexuality. That is the reason why you have promoted it. Thank you. They are from Hyderabad. Thank you.